Cortical Mastoidectomy by P.L. Dhingra, Chapter 80. Cortical mastoidectomy, known as simple or complete mastoidectomy or Schwartz operation, is complete excenteration of all accessible mastoid air cells and converting them into a single cavity. Posterior meatal wall is left intact. Middle ear structures are not disturbed. Indications 1. Acute coalescent mastoiditis. 2. Incompletely resolved acute otitis media with reservoir sign. 3. Marked mastoiditis. 4. As an initial step to perform A. Endolymphatic sac surgery. D. Decompression of facial nerve. C. Translabyrinthine or retrolabyrinthine procedures for acoustic neuroma. Figure 80.2 shows the various structures and landmarks seen after cortical mastoidectomy. Anesthesia. General anesthesia is preferred. Position. Patient lies supine with face turned to one side and the ear to be operated uppermost. Steps of operation 1. Incision. A curved post-oral incision about 1 centimeter behind but parallel to the retroauricular sulcus, starting at the highest attachment of pinna to the mastoid tip. In infants and children up to 2 years, the incision is short and more horizontal. This is to avoid cutting facial nerve, which is superficial in the lower part of the mastoid. Incision cuts through soft tissues up to the periosteum. Temporalis muscle is not cut in the incision. 2. Exposure of lateral surface of mastoid and McEwen's triangle. Periosteum is incised in the line of the first incision. A horizontal incision may be made along the lower border of temporalis muscle for more exposure. Periosteum is scraped from the surface of mastoid and posterior superior margin of osseous meatus. Tendinous fibers of sternomastoid are sharply cut and scraped down. A self-retaining mastoid retractor is applied. 3. Removal of mastoid cortex and exposure of antrum. Mastoid cortex is removed with burr or gouge and hammer. Mastoid antrum is exposed in the area of suprameatal triangle, that is McEwen's triangle. In an adult, antrum lies 12 to 15 mm from the surface. Horizontal semicircular canal is identified. Keep in mind the presence of corner septum, which would need removal to explore the antrum. 4. Removal of mastoid air cells. All accessible mastoid air cells are removed, leaving behind the bony plate of tegmen tympani above, sinus plate behind, and posterior meatal wall in front. 5. Removal of mastoid tip and finishing the cavity. Lateral wall of the mastoid tip is removed, exposing muscle fibers of posterior belly of digastric. Zygomatic cells situated in the roof of zygoma and retrosinus cells lying between the sinus plate and bony cortex behind the sinus are removed. A finished cavity should have beveled edges so that soft tissues can easily sit in and obliterate the cavity. 6. Closure of wound. Mastoid cavity is thoroughly irrigated with saline to remove bone dust and the wound is closed in 2 layers. A rubber drain may be left and the lower end of incision for 24 to 48 hours in case of infection or excessive bleeding. A meatal pack should be kept in to avoid stenosis of ear canal. Mastoid dressing is applied. Figure 80.1 Cortical mastoidectomy. Posterior meatal wall is left intact. Tegmen tympani, horizontal semicircular canal, short process of incus, sinus plate, facial nerve. Postoperative care 1. Antibiotics started preoperatively are continued postoperatively for at least 1 week. Culture swab taken from the mastoid during operation may dictate a change in antibiotics. 2. Drain if put is removed 24 to 48 hours and sterile dressing done. 3. Stitches are removed on the sixth day. Figure 80.2. Various structures and landmarks seen after cortical mastoidectomy. Sigmoid sinus plate, digastric ridge, site of endolymphatic sac, Donaldon's line, cranial nerve 7, anterior, posterior, up and down. Incus, Trotman's triangle, synodural angle or Sitterley's angle. Complications 1. Injury to facial nerve. 2. Dislocation of incus. 3. Injury to horizontal semicircular canal. Patient will have postoperative giddiness and nystagmus. 4. Injury to sigmoid sinus with profuse bleeding. 5. Injury to dura of middle cranial fossa. 6. Postoperative wound infection and wound breakdown. Types of post-oral incisions: A. Post-oral incision in adults. B. Post-oral incision in infants. Thank you.